Adolescence is a time of major transformation in the human body. For young females, this period brings rapid physical growth, hormonal shifts, and neurological development. While these changes are a normal part of growing up, they can also increase the risk of developing or worsening certain health conditions, especially adolescent idiopathic scoliosis, AIS. AIS is the most common type of scoliosis and usually appears between the ages of 10 and 16. What makes this condition so challenging is its tendency to progress during puberty, often rapidly and without warning. The link between puberty, growth spurts, and curve progression is especially strong in females, who are 8 times more likely than males to experience moderate to severe curve progression. Understanding the reasons behind this gender difference requires a closer look at how growth and hormones interact with the spine during this critical phase of development. The vulnerable spine, growth and structural instability. During puberty, the body undergoes a phase called the adolescent growth spurt, a time when bones grow quickly, especially the long bones in the legs and the vertebrae in the spine. For females, this growth spurt typically begins between the ages of 10 and 12 and continues for a few years, peaking just before or around the time of their first menstrual period, menarche. At this stage, the spinal column is rapidly lengthening, often growing several inches in a matter of months. While growth is a sign of health and development, it also creates a temporary window of vulnerability. As the spine grows taller and longer, it becomes more flexible and less stable. If muscle strength, posture control, and bone density can't keep up, the spine may begin to shift or rotate, leading to the development or worsening of scoliosis. The faster and earlier the growth spurt, the greater the risk. In girls with AIS, spinal curves that were once mild or barely detectable can become severe in a short time. A curve that measures just 10 to 15 degrees before puberty may double or triple during the growth spurt if not managed properly. Clinicians often monitor the Risser sign, a measure of skeletal maturity, and height velocity, rate of growth in inches per year, to help predict when curve progression is most likely to happen. Girls who are still growing and have low Risser scores are considered at the highest risk for progression. Estrogen, growth plates, and ligament laxity. One of the most important changes that happens during puberty is the increase in estrogen production. Estrogen is a hormone that plays a major role in sexual development and growth in females. It helps close the growth plates in bones, signals the body to store calcium, and influences how soft tissues like ligaments and tendons behave. However, estrogen can also have unintended effects on the spine during this time. In girls with AIS, there is often evidence of abnormal estrogen signaling. For example, estrogen receptors in the spine and surrounding tissues may respond too early, too late, or too weakly to the body's hormonal cues. This can lead to ligament laxity, a condition where the ligaments that support the spine become too loose and stretchy. When ligaments cannot properly support the vertebrae, the spine is more likely to lean, twist, or collapse into a curved shape. Additionally, estrogen plays a role in the closure of the epiphyseal growth plates in bones. In some girls with scoliosis, there is a delay in growth plate closure, which allows the spine to grow longer but also extends the window of risk for curve progression. In other words, the longer the spine continues to grow, the longer scoliosis has an opportunity to worsen. Progesterone, melatonin, and bone health. Another hormone that becomes active during puberty is progesterone. While it's most often linked with reproductive health, progesterone also affects the brain and nervous system. It plays a role in regulating GABA, a neurotransmitter that helps relax muscles and balance tone across the body. Low progesterone levels or poor GABA function can lead to uneven muscle activity, which may worsen spinal imbalances and drive curve progression during puberty. At the same time, melatonin, the hormone that regulates sleep, also influences growth and bone development. Some studies show that girls with AIS may have melatonin deficiencies or issues with how their bodies respond to melatonin. Since melatonin levels peak at night, when much of bone growth occurs, poor melatonin function may affect how the spine grows and repairs itself, especially during high growth periods like puberty. Girls with scoliosis are also more likely to have lower bone mineral density, BMD, than their peers. This makes their spines less able to resist the everyday forces of gravity, posture, and movement. During a growth spurt, when these forces are magnified, weaker bones may be more likely to give in to asymmetrical pressure, further accelerating curve progression. Curve progression and timing of menarche. One of the most useful clinical predictors of scoliosis progression is the timing of menarche. Most curve progression in AIS happens just before or within 1 to 2 years after a girl's first period. Girls who reach menarche later than average are often at higher risk, as this means their growth spurt lasts longer, giving scoliosis more time to worsen. Even after menarche, the body may continue to grow and change, especially if the spine has not yet reached full maturity. This is why early detection and close monitoring are so important in girls with scoliosis, especially in the years surrounding their first period. Asymmetrical spinal cord to spinal column growth rates. A low progesterone to estradiol E2 ratio during adolescence can significantly affect the coordination between spinal cord growth and spinal column elongation, potentially contributing to scoliosis curve progression. Estradiol, a powerful form of estrogen, promotes rapid skeletal growth during puberty, particularly in the long bones and vertebrae. When estradiol levels are high and unopposed by sufficient progesterone, the spinal column may elongate more quickly than the spinal cord. This mismatch can lead to a phenomenon known as asynchronous neuroosseous growth, where the spine outpaces the spinal cord's ability to stretch along with it. As a result, tension may develop within the spinal cord and surrounding neuromuscular structures, creating asymmetrical forces on the vertebrae and contributing to spinal curvature. Progesterone plays a critical balancing role, not only in regulating estradiol's effects, but also in supporting GABA activity in the brain and maintaining muscular tone symmetry. Low progesterone relative to estradiol can impair neuromuscular control, leading to uneven muscle activation along the spine, which further amplifies structural imbalances. In adolescent females, this hormonal imbalance is particularly relevant, as their bodies often undergo rapid changes in hormone levels during early puberty. When the progesterone to estradiol ratio remains low for extended periods, it may create the perfect storm: accelerated spinal column growth, reduced neuromuscular coordination, and increased mechanical stress, all of which are key contributors to scoliosis curve progression. Understanding and potentially correcting this hormonal imbalance could offer new pathways for early intervention and prevention of curve advancement in at-risk patients. Neuromuscular control and balance challenges. Puberty also brings changes to the nervous system, which can affect posture, movement, and balance. Girls going through growth spurts often experience a loss of coordination, awkward posture, or clumsiness. This happens because the body is changing so quickly that the brain and muscles need time to adjust. In AIS, this adjustment process can go wrong. Some researchers believe that adolescent girls with scoliosis may have impaired proprioception, the brain's ability to sense the position of the body in space. This can cause uneven muscle tone or poor posture habits that encourage the spine to curve. Moreover, asymmetrical muscle activity has been observed in many girls with AIS. Muscles on one side of the spine may be overactive, while the other side is weaker or underdeveloped. These imbalances may not be obvious at first, but over time they can apply uneven pressure to the growing spine, encouraging further rotation and curvature. Becoming a woman. In adolescent girls, puberty is a time of intense biological change, and for those with a genetic predisposition to scoliosis, it creates a perfect storm for spinal curve progression. Rapid growth, hormone imbalances, loose ligaments, delayed skeletal maturity, and changes in balance and posture all combine to increase the risk that a mild curve becomes a serious deformity. That's why early detection, personalized monitoring, and whole-body treatment strategies are essential. By understanding how puberty and growth spurts impact scoliosis, especially in females, we can better support patients during their most vulnerable years and help prevent scoliosis from progressing when the stakes are highest.